Okay. Hi friends. So this is a follow-up to the case that we described a week before about ruptured pseudoaneurysm of aorta to RVOT and aortic PVL in a same patient. We showed the 3D printed model of the patient, and today we did the case and we want to talk about that case. How did we go about it? So first of all, as the history goes, he is a 48-year-old male patient having rheumatic heart disease and has undergone double wall replacement way back in 2006. He developed a PVL few months after surgery and managed medically. Now he developed new onset breathlessness on exertion and weight loss. The echo showed large paravalvular leak. LALV were dilated, good LV function. RV was unusually dilated a bit, and there was an artifact coming in RV OT from LV, as you can see on this clip. And see, the leak is really severe. Now we did a CT scan, and as you know, we found rather than paravalvular leak, one more thing, a pseudoaneurysm which had ruptured into the RVOT. This is the working view that we got through CT scan. We are going to take a separate webinar on this, how to calculate this, how to find this working view of PVL based on CT scan. For now, this was the view in which we saw the PVL and the RSOV separately, and we went for that view during our procedure. This is the same angulations, 37, 23, somewhere like that, and I have taken a shoot. This is the leak which is coming through, where the leak is going to the LV and RVOT in both the directions. Then I came up with a multi-purpose catheter on just a J-tip wire, simple Teflon wire, and I tried to cross first the ruptured pseudoaneurysm, which crossed fairly easily. Once this was done, I positioned a JR catheter near the paravalvular leak by anti-clocking it and looking posteriorly. And from there, I pushed a Teremo wire straight tip. And as this is very important step, as you see, the Teremo wire actually goes from the tip of the JR in an oblique fashion below the aortic valve and then enters the LV. This is the direction of the leak, and the wire will follow the direction of the leak, which is very important to understand. If you try to poke in some direction thinking that there is a leak and the wire will go, you will have a lot of problems. The direction of the leak is below the valve in certain way, which 3D print also showed, even virtual reality showed in a better way, and we followed the track, and that's why we could cross it in a jiffy. Once we entered the LV, we put a pigtail there, and we positioned a safari wire there. Safari wire is a tower wire used for tower procedures. It is like a jalebi wire for BMV, but much more stiffer, having the stiffness of somewhere like an antar super stiff wire. But it gives much more support, and it protects us from rupturing the LV also. This case, I needed more support than usual, and see, in this case, in the end, somehow I had pulled the wire, but it did not come out because it had a J shape, and it got stuck into the wall, and that helped me. Subsequently, I was able to push the wire in, and I positioned a Fubuki catheter. This catheter is a neurointerventional catheter, very supple catheter, very lubricious catheter. There are a few catheters which can be used and traditionally being used for paravalvular leak closure, like a flexor sheath which comes from Cook company. It is also very lubricious catheter, braided catheter, and it can enter a very narrow paravalvular leak origins also. I found that Fubuki was very smooth to enter LV in whatever direction we have to push. Minimal push is required to get it into LV. While pushing this catheter also, the maneuver that I did was I pushed the catheter till the LV apex and then tried to remove the safari wire, because the tendency of the catheter was to go oblique as the leak was oblique. Then I pushed another neurointervention catheter, a striker catheter, into LV. I could have pushed here also simple flexor sheath, but I had striker available. I just tried it this time. These catheters are just 6 French catheters, which are larger inner lumen through which we can put, we can push larger devices. That was the whole point of putting this neurointervention catheters. Then I came up with a device. I don't think it's a new device. It's a known device now. It's Konar MF Device. The size that I chose was 10 by 8 mm. So this device is basically a PDA device with a separate disc on the RV end. So what I am coming up is using an RV end to put first, and I'm just pulling it towards the aorta, and I have half opened the belly of the device so that it will hinge onto the defect. So you can see that the belly of the device is half pulled. I will be slowly coming up. This is where it lands, and I'll slowly unsheath the device rather than pushing it. I get a nice apple core there that shows that the device is well sized. It is not undersized, otherwise it will embolize. In the next step, I tried to actually push the LV end or the aortic end down so that there is enough space there. The reason that I took closed the pseudoaneurysm first rather than the leak is I want an interconnection between both the devices, and I felt that by putting this larger device here, the one part of the disc will be near the leak, and that will create a kind of a constriction in the leak, and that will help in interlocking the devices. Next step, I came up with a device which is a Amplatz vascular plug type 2. I did not use an Amplatz vascular plug type 3 here because I wanted interconnection here. Amplatz vascular plug type 3 is a rectangular device versus it is kind of an oblong device, whereas this device is having three parts, two discs and a belly. All of them are of the same size. It is 12 mm here, and the length of the device is 9 mm, which is good enough for me to cover the length of the paravalvular tract and cause an interlocking with the other device that I have placed in the LVOT, in the RV route, aortic route. So now we are coming back, and here also I have opened the belly a bit. I have opened the left sided disc, opened the belly, and I am falling back with the opened belly. And I wanted that because I want to cover the whole defect with the belly rather than just the disc, so that it has a better occlusion. I was happy with this position, and this is how they are like in a oblique fashion, interconnected to each other, less chances of embolization because of that. And I can see that the valve leaflets are also moving very well, so we have not caused any obstruction there also. Then we took an angio. The angio was through the sheath connected to the device, which is showing a lot of leak, but you can see properly that the leak is through the devices. It is not away from them, and that means that it will seal off eventually. But we did try a little bit of adjustment with the pseudoaneurysm device, the Konar MF. We tried to pull it a bit and position it a bit higher so that there will be maybe a better interlocking. So you can see that I'm trying to do that. So here I have pulled it upwards. It seems that the devices are now better interlocked. Then I tried to deploy the devices sequentially. First the paravalvular leak device. The injection shows that still there is leak, but through the devices only. There is no leak around the devices. It is through the devices. I will deploy the paravalvular leak now, and the PVL device now, the ABP2. So I have deployed it. It is remaining stable. Now I deployed the Konar MF device. It is also remaining stable, but in the process you can see that it has dipped down a bit. That was eventually going to happen. That is what happens with the nitinol devices. Both these devices do not have a lot of fabric in them, and as a result there will be some paravalvular leak around it, which we will see, which we saw in the last shoot. We have accepted that, and I feel that in eventually over a period of 1 to 2 months there will be formation of clot in the devices, and this leak will completely stop. So this is the whole procedure where we have done closure of both the defects simultaneously in the same setting. We used two devices of two different morphological proportions, and they were positioned in such a way that they would interlock with each other so that they do not embolize, and they would serve the purpose of closing both the defects. The important teaching points in these cases are, first, that a case which is so complex can be made simple by good planning using CT scan and maybe using 3D printing in such cases where we do not understand the location, the extent, and the complexity of the lesions. And by finding a proper angulation of a paravalvular leak and something like this kind of a pseudoaneurysm which is coming from certain locations which we do not know, maybe we will be able to enter them very easily, very swiftly, and it takes away the sense of that these procedures are really difficult and we should not do it, to a thing that they can be planned and then can be made simple. The devices that we used, we will be showing them in the infographic later on. Thank you.